Hello there, I'm Bradley White, and today I'll be talking about ADHD and traumatic brain injuries. So first, just some key terms here. We're going to be discussing both a high incidence disability and a low incidence disability. So high incidence disabilities are disabilities impacting learning that appear more frequently in educational settings at around a rate of 80%. Some examples include dyslexia, communication disorders, mild autism, and of course, ADHD. Low incidence disabilities are disabilities impacting learning that appear less frequently in educational settings at a rate of around 20%. Examples of this include severe intellectual disabilities, blindness, and traumatic brain injuries. Now I'd like to talk about ADHD and traumatic brain injuries in succession to really focus on one and then the other. So we'll start with ADHD. The American Psychological Association has described attention deficit hyperactivity disorder as a behavioral condition that makes focusing on everyday requests and routines challenging. Of course, there is a great degree of subjectivity in diagnosing ADHD. There's not one concrete method. As a result, diagnosis relies on reports from parents and teachers, and the final diagnosis is contingent upon the child exhibiting 6 of the common symptoms for at least 6 months in multiple environments. These symptoms are broken into 2 categories. First, inattention. People with ADHD may have trouble attending to details, sustaining attention, organizing and following instructions. They might be easily distracted or dislike tasks that require extended focused mental effort. They might lose things frequently or be forgetful. The other category is hyperactivity and impulsivity. People with ADHD may frequently fidget, be restless, talk excessively, interrupt others, act thoughtlessly, and have self-control issues. When teaching students with ADHD, there are many different ways to help them deal with their challenges. Many of these focus on dealing with the executive functioning skills and concentration. First, when it comes to content, you can chunk information into short, clear segments. Chunking information helps to prevent the student from being overwhelmed and allows them to more easily grasp and retain key ideas and concepts. While you're actually in the midst of teaching the process, you can use interactive hands-on activities. The use of interactive lesson materials increases engagement for these students and also provides an outlet for that excessive energy, all the while promoting the retention of learned information. When it comes to the product, offering these students choice for how they'll demonstrate their learning has been found to be extremely beneficial. Choice in learning not only improves motivation and engagement, it caters to the student's strengths, allowing us to get a more accurate assessment of their understanding of the material. There have been a number of learning technologies that have been developed that have been found to be very beneficial for students with ADHD. First, game-based learning. Utilizing digital applications such as Kahoot, Bookit, and Quizzes, these things transform learning into a video game, thereby raising the level of engagement for these students and improving learning. There's also audiobooks and recorded lessons. So audiobooks and recorded lessons have been found to improve student learning by improving specifically their control over the pacing and the time and place of their exploration of class materials and content, improving their ability to understand the material by giving them control and empowering them. Finally, to help with executive functioning skills, we have digital to-do lists and task management apps. Research has found that applications devoted to utilizing time effectively like ChoiceWorks, Todoist, and Google Calendar can be effective for both helping students with ADHD manage their time and, more specifically, deadlines, and reinforcing important executive functioning skills and strategies. Now, as impulsivity is a part of the ADHD galaxy of symptoms, we want to make sure that we're providing appropriate behavioral supports. So here are 3 that are research-based. First, correspondence training. This technique asks students or children with ADHD to make a commitment statement, such as, "I will clean my room before we leave," and they'll do that either verbally or sometimes in writing. After a set time has passed, a parent or teacher will check to see if the child has actually followed through on that commitment statement. If so, positive reinforcement is given. And this technique encourages accountability and the ability to self-regulate. Speaking of that, we have self-monitoring behavior. After identifying behaviors in need of change or improvement, the student is then placed in charge of observing and recording instances of that behavior and reflecting on those observations. And this strategy has been found to improve behaviors and foster self-determination. Finally, we have the daily report card. After determining key challenging behaviors and developing goals, teachers, parents, or other key figures relating to the student offer a rating on the student's performance over the course of the day. Consistent positive progress towards those goals is rewarded, and this practice has been found to improve behavior as well as provide useful data that can be used later to determine the student's needs. As with all students, it's important to keep family background in mind in terms of how that background impacts their learning outcomes. So after some research, I developed this claim. Students with ADHD from families with lower socioeconomic status often face greater challenges in achieving positive outcomes in educational settings. And to back this up, I found quite a great deal of literature and information. The first piece is the article Healthcare Disparities and ADHD, which noted that lower socioeconomic status may result in lower rates of ADHD diagnosis and related services. Specifically, insurance, as well as limited access to quality providers, often dictate who can be seen and why, before individuals and families even have the chance to voice their concerns. So students with a low socioeconomic family are unfortunately going to be prevented from even accessing the resources they need to get started in getting help. The second piece I looked at is called ADHD Remission, Inclusive Special Education, and Socioeconomic Disparities, which found the following. Low socioeconomic status children did not show substantial improvement when receiving a combination of medication and behavioral treatment. Low SES children with ADHD are more likely to have unmet needs than their high SES counterparts, and low socioeconomic status children's remission rates are higher in the most inclusive states than the least inclusive states. However, in contrast, high SES children's remission rates did not vary significantly in more or less inclusive states, showing us that those low SES students are still at a higher risk of not going into remission for their symptoms. Now I'd like to talk a little bit about traumatic brain injuries. So key elements of the IDEIA definition of traumatic brain injuries are: the injury is caused by either the penetration of the skull or blunt force causing the brain to hit the cranium. The injury results in either partial or total functional disability and or psychosocial impairment. The injury results in impairments in one or more areas such as motor abilities, cognition, physical functions, and psychosocial behaviors. And the injury is not congenital, generative, or caused by birth trauma. Symptoms are very complex and they vary depending on how severe the injury is, where the injury occurred, the age the individual was when they were injured, and how much time has passed since the injury has happened. And we divide these symptoms into three categories: physical and sensory changes such as recurrent seizures, hearing impairment and poor sense of balance, cognitive impairments and academic problems such as inflexible thinking, impaired reading, comprehension, and difficulty with transitions. We have social, emotional, and behavioral problems such as low impulse control, chronic agitation, and reduced sense of self-awareness and the awareness of others. Now, when we're differentiating instruction for those with TBI, we have to remember a few things. Due to the complex and widely varied symptoms possible for those with TBI, the strategies implemented to aid them in the classroom must be carefully tailored to the needs of the student with this disability. Below are a broad array of strategies that might potentially be employed. So for content, you could simplify texts or present in a multimodal fashion or allow students to record lectures or provide recordings. For the process, you could establish and maintain consistent routines or allow students to respond at a pace that matches their needs. And for the product, you could allow open note tests or break assignments into smaller pieces with breaks in between. The same is true for the use of learning technologies. Similar to the realities of differentiating instruction for students with traumatic brain injuries, the use of technology in aiding their learning must be highly individualized. So here is some commonly utilized tech within that frame. First, text-to-speech apps. As many students with traumatic brain injuries experience cognitive challenges, text-to-speech applications can help improve reading comprehension and understanding of key material by lessening the cognitive load. There's also emotional self-regulation tools and apps. Traumatic brain injuries often result in emotional dysregulation, chronic agitation, anxiety, and unpredictable mood swings. Apps such as Calm and Breathe, Think, Do can help students manage their emotions by providing coping strategies and providing insight into patterns. Finally, we have assistive communication devices. Communication challenges are frequent complications for those with traumatic brain injuries. Tools such as augmentative and alternative communications devices allow students to bridge those communication gaps. Behavioral supports are also highly varied and can include things like structured environment. Environment should be structured in a manner that limits or prevents challenging behavior. We can also teach them self-regulation strategies. This strategy focuses on teaching students to notice their emotions so that they can then control them. And then finally, consistent routines. Consistent, predictable routines decreases anxiety for students with TBIs. When we reduce the stress for those students, the likelihood of challenging behaviors decreases. When we're thinking about family background's impact on students with TBIs, we'll find some very similar results when it comes to TBIs as with ADHD. After some research, I determined the claim students with TBIs from families with financial disadvantages and or with caregivers with lower levels of education often experience difficulty in educational settings. My first piece of evidence comes from Update on Pediatric Mild Traumatic Brain Injury in Rural and Underserved Regions, a Global Perspective, which found that limited parental education and low household income were associated with a greater worsening of executive functioning at 12 months. Outcomes at 6, 12, and 24 months were substantially poorer than baseline for children with the least educated parents. So this is really showing us that though these children are young, this is going to be a pattern throughout their education. To further that, we have our article, Effect of Parental Education and Household Poverty on Recovery After Traumatic Brain Injury in School-Age Children, which found that outcomes at 6, 12, and 24 months were substantially poorer than at baseline for children with the least educated parents. After moderate severe TBI, children in households with lower incomes had poorer outcomes compared to baseline across time. Now, there is quite a range of different advocacy groups for both ADHD and TBIs. I just wanted to quickly list some of these here. We've got CHAD, very useful, provided me a great deal of information about ADHD. We have the Attention Deficit Disorder Association, the American Academy of Child and Adolescent Psychiatry. On the traumatic brain injury side, we have the Brain Injury Association of New York State, the Center for Neurobehavioral Health at SUNY Plattsburgh, and BrainLine, again, an incredible resource for me as I was putting this presentation together. To conclude, I've got my references here. Thank you so much for listening. Have a great day.